I guess I often feel like I'm kind of the bad guy in the room when I come in, because I'm usually the one that says we're changing this, this, and this, and here's your new prescription, and we'll see you again soon. So it's a matter of kind of managing what's in the lineup. This is usually the drill, how renal clinic starts. When we have a new patient, they come in with their lovely, slightly contaminated bag of medications that you're not sure where they've actually been. And then that's me, not usually as a man, staring down the end of a table at a whole lineup of pills. So this is my box I get to stay within. The one at St. B has a little extra room for writing. So my priority list is usually talking to the patient about why they're taking most of the medications, because if they have no idea why, they're never going to take them, and they're not going to take them well. Talk about nephrotoxic drugs again, because I don't think that can be emphasized enough. It's really disheartening to see someone who was previously stable and then comes in with a GFR of like 5, and it's usually because the Aleve bottle was on the counter. So talking about that, looking at appropriate dosing for their level of renal dysfunction, going over anemia, EPO, mineral metabolism, which I strongly rely on the dietitian to help change their old ways of eating. And we try and give patients as many chances as we can. I think the dietitians are often more optimistic than I am that they'll change, and I prefer to be a little more aggressive. And then the last thing is cardiovascular risk reduction, which, as Paul demonstrated, is a huge issue with our population. So we'll go over some of the slides. I'm going to skip through a lot of them, because this is just kind of like baseline things you need to know. So our goal is 130 over 80. We're pretty sticky about this goal, because if you don't control the blood pressure, we do see these people progressing a lot faster. We utilize ACEs and ARBs, but really when they start progressing a lot faster, we don't discriminate. We'll use any antihypertensive we can that will allow the patient to stay off of dialysis. And the ACEs and ARBs, I think we often see people being a little more hesitant towards using them as the renal function starts progressing, but when they are in CKD clinic, we're monitoring them, and if we do see a large jump, then that medication will be stopped. So diabetes, as Joanne has said, our A1C less than 7% is our goal. Metformin we're fine with as long as their kidneys are above 30%. If they are not, then that medication goes out the window just because of the risk of metabolic acidosis, and it's often not providing them with a large amount of benefit. We like to choose glycoside. There's also butamide, which is metabolized to inactive metabolites, versus glyburide, which goes into active metabolite and will often cause hypoglycemia, which we'll get to is likely to cause in this case. And looking at their risk for hypoglycemia and how they actually manage their low blood sugars is also a huge concern. Dyslipidemia, we will do fasting lipid profiles every 6 to 12 months. Our reductions are the same as demonstrated with cardiovascular disease, so decreasing the LDL, well, these slides are different, LDL less than 2 or the ratio less than 4. High triglycerides we will look at. We usually won't treat until they're greater than 10, and we prefer using gemfibrozole versus the other fibrates, because this does not require a dose reduction in decreased kidney function. We probably do kind of lean towards more statin use than fibrate use, and we try to steer away from the use of combination in these patients due to the risk of rhabdo. So this is just a quick slide, which I'm sure you can access these slides later on, just about dosing. Keep in mind, we usually will use atorvastatin, simvastatin, and rosuvastatin as kind of our main go-to statins. Just to bring up a trial that was previously presented at ASN in 2010, this SHARP trial, which our centers did participate in. And this is the first randomized control trial that actually showed a benefit in this population. So this population had never really been studied before. We have hemmed and hawed about whether statins are useful in dialysis populations, but With the SHARP trial, this did demonstrate a 17% reduction in major atherosclerotic events, which was statistically significant. This study did use simvastatin and ezetimibe versus placebo. I'm not really sold on ezetimibe, and I think titrating the simvastatin might have been a little a better thing that we would have done in clinical practice. So talking about anemia goals, our goal hemoglobins with CSN was 100 to 120. The MRP has recently kind of revamped this thought, and we are at 105, I believe, to 120 is the new guideline that we're following. Iron stores, ferritin, we want over 100, and the TSAT above 20%. We'll start Eprex if they have adequate iron stores and their hemoglobin is less than 100. I'm more erring on the side of caution, and I usually wait till it's in the 90s and they're actually feeling symptomatic before starting Eprex. And if they are receiving Eprex and they have inadequate iron stores, we'll start iron therapy, either oral or IV. If their hemoglobin is slightly low and they're not on Eprex, we'll usually start oral iron. So just a couple notes about Eprex. The Eprex is covered by the Manitoba Renal program. However, we only distribute it out of 2 sites, which is Shoppers Drug Mart at St. Boniface Hospital and the HSC Pharmacy in Psych Health. The patient is not billed for the cost of the drug, which starts at around $300 and escalates up from there. It is covered through NIHB, and so it can be filled anywhere. The nurses do a great job of training the patient. If they don't have the ability to inject the needles themselves, home care has been involved. And just another note, it's not made in 7,000 or 9,000 unit syringes, so we actually won't combine any syringe strengths in terms of dosing. Is just painful and increases the cost. And patients often think that the needles get stuck in them, but the needle actually retracts into the syringe. So it's always a good teaching point. So in terms of anemia evidence, yeah, it happens. So there's been 3 studies. We've had Choir, Create, and Treat in terms of looking at Eprex therapy in a CKD population. I think the beginning of the Choir actually was the reason for putting a black box warning on Eprex from the FDA, because there was an increased risk of death and there was an increased risk of cardiovascular events with high hemoglobin targets. So we've kind of moved on from Choir and Create and went to Treat, and Treat was published in 2009. There's a lot of writing on this page, and I actually have a different slide which isn't in here, but Treat showed us that patients who previously had cancer had higher risks of mortality, and patients who had higher hemoglobin targets or rapid rises in hemoglobin were shown to have higher risk of stroke and death. So we keep our hemoglobin target less than 130, so we max out at 120, and that's kind of where we try and keep our patients between. If we see a rapid rise in hemoglobin, there's a rapid reduction in their dose of Eprex. And they do continue to be made, dose adjustments are made up based on trends and not just a single hemoglobin. So just about mineral metabolism. So with the mineral metabolism, the cost-effective way of managing this is using calcium carbonate. We don't promote them using over-the-counter calcium supplements because they often are derived from like oyster shells, which contain impurities. We will use sevelamer if we have to, which is also called Renagel, and it's a non-absorbable, non-calcium-based phosphate binder, and we use this if their corrected calcium is high. At minimum, it will cost them $150 a month, and often more, because these people do not have very well-controlled phosphoruses. So it's something you have to take into consideration about if these people can actually afford it. It does get covered by Pharmacare, but they still have to meet their deductible, and if it's the beginning of Pharmacare year, that's not usually the case. As Noreen had mentioned, we do use calcitriol to control PTH in the CKD population as well, but not in this case. Acidemia, just to touch on, we will only treat when the CO2 is less than 15, and we use sodium bicarb to treat it with. They are large pills, and no one likes taking them. So we will prescribe them if we have to. In this case, she's far too edematous to receive anything with a sodium complex on it. So restless leg syndrome, we use levodopa and carbidopa. We also will use dopamine agonists. We usually will use ropinirole versus pramipexole, which has to be dose reduced in CKD. The issue with this is you often get augmentation, meaning that it's not occurring at night anymore, it starts occurring in the morning. So you have to give them more medications often. And when they do go on dialysis, this might let up a bit. But there's also a lot of adverse effects to these drugs, including insomnia and GI disturbances. The more concerning ones often have been found with pramipexole, meaning that there's been impulse control disorders, and most recently in the news, there was someone who actually blamed their drunk driving and gambling on pramipexole, and this was supported by the courts. So just another word of warning in prescribing these sorts of medications. Quinine probably has the most evidence, however, it also has the most adverse effects, and our risk versus benefit ratio on this one, we prefer to stay away from these types of risks. So a lot of thrombocytopenia, uremic syndromes, which they might encounter on their own, tinnitus and nausea and vomiting, which can often mask the uremic symptoms that we're working for or striving to find. We usually will recommend things that are non-pharmacological first, so stretching and heat therapy. We use a lot of gabapentin in low doses, and often we'll use analgesics as well. So just a word on EGFR versus creatinine clearance. So creatinine clearance has always been used for drug dosing. This is a bit of a historical look, but the bottom line is that if you calculate a creatinine clearance and EGFR, they're usually within 5 mLs per minute of each other. And the dose reduction should always be based on the patient as well and the risk of the medication that you're using. So going to the case, this woman has quite a low hemoglobin. She also has some slight deficiencies in her iron. At this point, because there's going to be so many other changes made, we're going to sign her up for some IV iron, which will usually occur in a month. So we use iron dextran as first line. If there is a reaction to it that's deemed a non-avoidable reaction in the future, we will transition over to using Venofer from the patient. And the Eprex initiation, this person is quite a bit larger. I had subsequently changed the slide actually to decrease her dose to a starting dose of 4,000 units every 7 days. We can place more demand on her iron stores once we've repleted them. The diabetes issue, so we would discontinue the metformin. We would also discontinue the glyburide. We'd switch her to maximum dose glycoside. We'd give her a monitoring plan for her blood sugars that would actually be useful to us, not just random kind of blood sugars that you can't really interpret. And then also consider referrals to either UVL or this person's likely heading for an insulin initiation in the near future, so she would be likely referred to endocrine clinic. So hypertension, she has a strong history. She's quite hypertensive, but the edema seems to be the main issue here. So we would continue what antihypertensive she is on and then also start some furosemide. This person would be followed up likely in about a week with our renal nurses to reassess the blood pressure and the fluid management and see how she's doing. At that point, we can increase Lasix or start adding a different antihypertensive if it's indicated at that time. So I'm not crazy about her Plavix and aspirin. Her CHAD-2 score is only 2. However, I'm not sure if this is really indicative of her actual risk as a CKD patient. So she likely will need a little nitro spray. She's already wearing a patch, so I think you should always err on the side of caution. Her digoxin dose is quite high, so we're going to look at that. And anticoagulation, I think she should be sent back to cardiology clinic. There's more of an emphasis on using warfarin, so I think it's time to consider that versus this, and also see where that stent is placed. The cholesterol issue, her cholesterol is not within target, and we need to help to reduce that. So she's only on 10 milligrams of atorvastatin, so we would increase that to 40, watch her labs. If she does not see a rise in her liver function test, we'll increase it again. Gabapentin is probably one of the most overdosed medications we see in these clinics. So for her actual level of renal function, she is restricted to about 700 milligrams per day at most. So she's on quite a hefty dose that we would dose reduce as well. She's also a smoker, so we will offer her cessation therapies as well. She has a history of hypothyroidism and no treatment for that, so we'll look at her TSH.